So the basic primary research question we wanted to ask is, can teriparatide replace percutaneous vertebral augmentation for patients with osteoporotic compression fractures? For this, we first need to know what osteoporosis is. It is a metabolic bone disease characterized by low bone mass and microarchitectural deterioration of bone tissue, leading to increased bone fragility. The historical old classification of osteoporosis was primary and secondary. Primary being divided into juvenile, idiopathic, postmenopausal, and senile osteoporosis, with the postmenopausal and senile being the most common causes. The newer classifications were given by WHO, dividing the osteoporosis based on DEXA scans and the T-scores, with osteoporosis being less than minus 0.5. WHO also gave classification based on the fracture risk assessment, dividing the risk into low risk, high risk, and very high risk. Why should spine surgeons treat osteoporosis? That is the basic question. Because vertebral compression fractures, which we find in our OPDs, are the most common cause of it is osteoporosis. The vertebral fractures constitute 50% of all osteoporosis fractures. 25 to 60% of Indian postmenopausal women are estimated to have osteoporosis. History of two vertebral compression fractures is the strongest predictor for future vertebral fractures and hip fractures in postmenopausal women. The basic objectives of our study was to compare the clinical outcomes, that is pain relief and functional outcomes, of patients with vertebral fractures caused by osteoporosis treated with vertebroplasty versus conservative management using teriparatide. The method used was the retrospective study. 60 patients were included in the study, with 30 being in each group. Pain assessment was done by visual analog scale and subsequent follow-ups, and the functional outcome was measured with Oswestry Disability Index, assessed at 3 months and 12 months. So the fracture healing evaluated via radiographs at 3 months and 12 months. Complications were of course documented during the 12 months follow-up. The inclusion criteria being patients aged 50 years and older. Diagnosis was done by X-rays, CT scans, and MRIs. Nature of the fractures was stable osteoporotic vertebral fractures with no kyphosis and no dynamic collapse, no neurological deficit. Treatment groups were patients who received either vertebroplasty or teriparatide injections. Baseline pain assessment with visual analog scale more than 4 were included in this study. The exclusions were patients with comorbidities like cardiovascular, pulmonary, neurological disorders, or any malignancies. Previous treatments like vertebroplasty or surgeries, if the patient had, then we excluded those patients. Other treatments like concomitant osteoporotic treatments, if going on, were also excluded. Cognitive impaired patients, fracture type specifically, pathological fractures, traumatic fractures, unstable fractures, and fractures with dynamic collapse were excluded. Neurological deficit patients were also excluded, and during the course of the study, if a patient had new vertebral compression fractures, those patients were also excluded from the study. Each group for conservative management was given teriparatide injection, which were given daily, calcium and vitamin D supplements, and braces if required. And the second group was treated with percutaneous vertebroplasty and was treated with vertebroplasty, and calcium and vitamin D supplements were given, and no anti-osteoporotic treatment was given for this group. So this is the basic design of the study. With confirmed osteoporotic vertebral fractures, inclusion criteria was selected. The conservative treatment patients were followed up. If any adverse events had happened during the course of 12 months, then vertebroplasty and stabilization, if required, was suggested. In the vertebroplasty group, if during the course of 12 months, if any new vertebral compression fractures had occurred, then the teriparatide injections were started, and those patients were excluded from the study. Results are basically the pain relief. Immediate pain relief was observed with VAS score reduction of 3 points on an average for vertebroplasty group, and conservative group, we didn't find any immediate pain relief. Long-term outcome was shown no significant difference between both these groups. Uh, According to the functional outcomes, the ODI scores at 3 months showed improvement of 30.2 in vertebroplasty groups and 10.4 in the teriparatide group. Long-term functional outcomes specifically showed no significant difference. So these are some of the radiographs of conservative treatment at 12 months follow-up and percutaneous vertebroplasty at 12 months follow-up. In our discussions, Dr. Kong et al. Had published a paper in 2019 suggesting that any patients who had undergone percutaneous kyphoplasty and were given teriparatide injections showed less incidence of new vertebral fractures than those patients who had undergone a kyphoplasty but given only calcium and vitamin D supplements. So concluding our study, our findings were that vertebroplasty provides rapid pain relief and functional improvement in short term, but teriparatide can replace procedures such as vertebroplasty or kyphoplasty in patients who have fracture types which is stable, pain is tolerable for the patient, and no neurodeficit was found. Long-term outcomes for patients for pain and function are similar in both treatment options. Conservative management with teriparatide is a safe alternative, and especially for high-risk patients. Uh, Clinical implications for us is that we encourage discussion and at individual level, uh, assessing the patient risk profile. Start teriparatide in all patients treated with vertebroplasty or kyphoplasty. Thank you.